This is Meet Me at the Diner with your host, Ann Eller.
Oh, that's right. Good afternoon, everybody. How are you doing? We have a great show for you. If you've ever been in pain, you need to hear the show. Let me tell you, we are here with Dr. Sanal Agarwal, and he is with their pain management center at Self Regional Healthcare. We're going to be talking all about pain. So what can I say today? I feel your pain. That's right. I'm Ann Eller. This is WCRS. Meet me at the diner. Penny is sitting in the background here. If you're watching us on Facebook, I think you can actually see her face over my shoulder this afternoon. And it is with great pride that I bring to you Dr. Agarwal, and he has a bachelor's degree from the University of Michigan in Ann Arbor, a master's degree from Wayne State University of Medicine in Detroit. He received a medical degree from the University of Cincinnati, and then he decided to be smart and move south, and he came to Emory University Hospital in Atlanta, where he did an interventional pain medicine fellowship. So without further ado, I do want to say to you, how are you doing today?
I'm doing great. It's great to be here.
It's great to have you here. Now, how did you decide to get into pain? Did you have a lot of pain?
Well, fortunately, I haven't had a lot of pain so far, but something to anticipate maybe down the road. So pain's a great specialty.
Because we're all getting older, right?
As we get older, more people have pain. In medicine, we often think about improving people's lives by increasing how long they live. In pain management, we can also help improve the quality of life and their functional status as they get older. And so that's something that I found to be very valuable in my care for patients. And so people can do the things that they want to do as they age. From a technical standpoint, the field is growing pretty rapidly. There's a lot of things going on in the field, including different medications that are being introduced to the field, different interventions that we have available, and other complementary therapies that we can offer patients.
So so you found that interesting, and then how did you end up at Self Regional?
Yeah. So like you said, gradually been moving down south and did my training in Atlanta. Here at Self, there is a great opportunity to build a pain program. There is a large need for pain management in this community, and the hospital has been very supportive and hopeful to develop a pain program here. And so there is a very great opportunity to help build a pain program.
Now, how long has that program been in existence? For a long time, or are you actually building the program, and how long have you been here?
So there's been different pain providers who've been with Self Regional for a couple decades now. They've kind of rotated with different doctors over the last several years, and so there's some hope to develop some stability in pain management for the patients. Part of treating patients who are chronically ill is that you want to establish a relationship with those patients. You get to know those patients, and you know what's worked for them and what hasn't worked for them. And so if you keep changing doctors, then you don't have that continuity anymore, and so that kind of disrupts that care that they're getting. And so I've been there now 2.5 years and hoping to continue to build with providers who are going to be there for the long haul and provide care for this community.
What would be one of the biggest issues with pain? Now, from my perspective, and I'm not sitting on your side of the table, but from my perspective, we hear all the time about abuse with pain pills and this type of thing. Do you deal with much of that at the pain management center itself?
Absolutely. Our goal is to be thoughtful in the way that we practice pain management. And so we typically take a multimodal approach for managing pain. So whether or not that's non-opioid medications, opioid medications, interventions, complementary therapies, that those are all used together to address someone's pain. Now, there are patients who have been on pain medications, opioid pain medications specifically, for a long time, possibly from prior surgeries, prior conditions, prior providers. And so when we see those patients, we try to understand what role that medication is having for them and if it's the best thing or are there better alternatives to be on for those patients. And so we work with the patient. For folks who are a little bit harder to manage, we have our addiction specialist also help get patients on a safer regimen. And so it's a team effort to address patients who were concerned about their medication regimen.
Now, it sounds like to me you're not just handing out pills and sending them out the door. It sounds like it's quite a procedure to be able to understand their pain.
That's correct. We take pride in being thoughtful in our approach to taking care of patients. So, when we see a patient, we listen to them. We try to understand where they've been and where they're trying to go in terms of their management. And so we try to offer all sorts of things and see what the patient is interested in trying. But no, we're not just handing out medications. We're trying to be thoughtful in how we take care of people.
So now you have a team that works with you, and these people are experts in different aspects of pain.
Yeah, so we have a great team at Self. So we have 3 doctors, including myself. There's Dr. LaTourette, Dr. Antonovich, who's our newest add, and he's been great. He's been there for about a month and a half now, and then myself. We also have a great administrative lead in Brittany Dunlap, and we have a great clinical manager in Devin Strickland. We also have a very supportive and large nursing team that are wonderful to the patients, and they've worked very hard to make the whole system go. And then we also have a great team of CMAs who are very helpful in taking care of patients. And also, very importantly, we have a great team of 3 nurse practitioners who get patients seen in a timely fashion and take great care of our patients. So Jill Gilchrist, Kelly Artis, and Kitty Russell are all great team members that we have. And so we all communicate well with each other and work together to help provide great care for our patients.
Now, this is an outpatient service?
Yep. It's an outpatient service.
You must have a lot of people in pain here.
We do. I believe there's an aging population here in Greenwood. And so there's a great need to help improve quality of life and functionality in people who are aging. But it's not just for folks who are aging. It's younger patients, too, who may have had an injury or have some sort of pain generator that we're trying to address. And so there's definitely a huge need for pain. It's across the country, but I believe that we're the only pain group in about an hour radius. And so we see a lot of patients from about 7 different counties.
Wow, that's huge. That's huge. When you see a situation like Tiger Woods, which that he probably did have a lot of pain, but we see how his life devolved, I guess we should say. That this is a hard thing to deal with.
Right. And it's an unfortunate story. I'm not exactly sure what medications he may or may not be on or what exactly his pathology is. But it can be, debilitating. And, that's a struggle that is challenging to overcome. And it brings me back to the idea of expectation. So, once upon a time, and hopefully once again, he was a great golfer. But to now reshape his attitude and reshape the way he approaches his life is a very important thing that he is going to have to address. And so that's something that when we see patients, we also try to counsel them on is, yeah, maybe once upon a time you used to be a great athlete, but now in your older age, there may be a different set of goals that you should try to achieve. But again, our goal is to try to help people do what they're hoping to do.
Now, I would be curious about how about our athletes. I mean, we've got all kinds of student athletes, and they get banged up pretty bad, particularly, I think, in football. Do you see younger patients such as this, or is it mainly an older population?
So our patients are typically geared towards chronic pain patients. So that's usually patients who've had pain for about 6 months continuously. And so typically for younger patients who have an acute injury, if they have a broken bone or a torn tendon or some structural problem, that's usually managed surgically. If it's something that, requires physical therapy, then they go ahead and do that. We do have some younger patients, but for the most part, they tend to bounce back from those injuries a little bit
Sure.
more quickly. But again, if they meet that criteria for 6 months with chronic pain, then we try to provide them with alternative solutions.
Now, I'm just going off a little bit. What about cancer patients?
Yeah.
Do you see cancer patients?
We do see cancer patients. So there's a slew of different interventions that we do. Some are medication management. So we work with our cancer team, the palliative team as well, to come up with a multidisciplinary approach for how to address those patients' care. I do some injections as well that can help with certain types of cancer, but that's a complex problem that we're working to address.
Okay. All right. So we are here with Dr. Sunil Agarwal, and he is in the Pain Management Center at Self Regional Healthcare. So how do you what is chronic pain?
Yeah, so chronic pain, like I mentioned, folks who have 6 months of pain in the same area that's not resolving with more conservative therapies like physical therapy, or don't have a surgical solution for it, like if they broke a bone and having an orthopedic doctor repair that, or having a GI problem and having a general surgeon address that, or a colorectal surgeon address that. So we try to help folks who've already had their primary issue addressed in the appropriate manner, and if their pain continues, then we try to address their pain.
Now, to go to the pain management center itself, do you have to have a referral?
Yes, so a referral from either a primary care doctor. We get a lot of referrals from our surgical colleagues who've done the surgery and the patients still have pain, and so we require that as part of our referral pattern.
Okay. And what about back pain? Because everybody talks about back pain, right? Back pain, knee pain. What about all those type of pains? What are the types of things that you can do for that?
Yeah, so back pain is a pretty complex issue. It's one of the most common medical problems that people encounter. And so back pain sounds simple, but there's actually several things that can contribute to back pain. So you can have arthritis of your back, and so there are certain interventions that we can do for that to make you not feel the arthritis in that area. There are spinal nerves that you have in your back, and so aside from medication management, we do things like epidural injections, or can consider things that are more invasive, like a spinal cord stimulator, to address that. For folks who have narrowing around their spinal canal, we do an innovative procedure called the mild procedure, which is a minimally invasive lumbar decompression procedure.
You better say that again.
Yeah.
That's pretty complex. What do you got there?
Minimally invasive. So it's a small incision that we make, lumbar meaning back, and decompression where we open up that area. And that's a procedure done for folks who have narrowing around their spinal cord. And it can be helpful for them to be able to walk farther and stand longer. And the advantage of it is that you go home the same day. The recovery time is relatively quick, and then you do physical therapy for several weeks after to get you stronger again. And so it spares a lot of the recovery time that's included with certain other interventions. So that addresses spinal nerve.
Is it done with a robot? I mean, that sounds like that's pretty small, right?
Yeah,
there.
so it's done manually. So we have a device that we use to thin down a structure in your back that supports the spinal column, but sometimes when that structure gets too thick, it becomes the problem, or a contributor to the problem itself. And so we use a little ice cream scooper, for lack of a better term, to scoop away at this structure. And the advantage.
It sounds kind of dangerous. Is that a dangerous procedure?
Well, generally it's pretty safe.
It's pretty safe.
As
I
with
like this. Okay.
with any intervention that you do, there are risks associated with it. But the risks are similar to that of an epidural. So we have an X-ray machine that we're looking at with live imaging. We're monitoring the patient very closely. The patient is awake enough to be able to communicate with us. And generally, the risks are less than that of other possible solutions to that problem.
And is that something you actually do that procedure?
Yes. Myself and my two colleagues also do that procedure.
Is that I'll use the word popular thing to do?
It's gaining popularity as people realize what the outcomes are looking like, and the recovery time being as little as it is.
So is this a new procedure?
It's been around for over a decade now. It's gaining momentum as more insurance companies are recognizing that it's valuable, as more societies in the pain and in the medical world are realizing that it's safe and efficacious, and as hospitals are starting to adopt it too. And so when I came 2.5 years ago, that was something that I wanted to bring to this hospital, and so that's something we've been providing our patients.
That's pretty cool, isn't it?
Yeah, it is.
Yeah. It's got to give you a good sense, though, when you're able to alleviate someone's pain or make their pain so much less than it has been.
It is great. Now, the important thing is I don't ever say that I'm in the business of taking pain away. I try to set proper expectations. Our goals are to help you live a better quality of life, to improve your pain, and allow you to be more functional. To be painless is, something that I don't know if I have the power to contribute to.
Right.
But to improve your pain, that's something that I strive for.
You ever ask your patients, how much less pain do you have? 25%, 50%?
We do, and it's not a great question. We always ask, what's your pain now? Is it an 8 out of 10? Is it a 10 out of 10? And it's all relative, but it serves some value. I think it helps frame their pain to themselves.
Right.
It helps them say, is my pain better or is my pain worse? It makes them think about it. Maybe when we don't ask, they may say, hey, is my pain a 10 out of 10 or is it a 0 out of 10 or somewhere in between? And so it gives some ownership to them too, to the patients. And that's also a big strategy that we take on is it's not just expectation setting, it's also ownership of managing your pain. So, if your pain is worse when you go golfing, maybe you shouldn't do the full 18 holes anymore. And so you have some ownership of it.
You're a downer? You're a downer to these people?
It's part of setting expectations, maybe helping them realize that they have to listen to their bodies a little bit better.
Do you think as a public we just want instant fixes though, don't we?
That's true.
We want just to feel great all the time. If you can give me a pill that can make me great, I'll be happy, right?
That's true. That is what the people want. Unfortunately, it's not the reality of how things work, particularly with our bodies. And so it's a process. And, things like physical therapy, getting stronger, building your muscles, those are valuable in your pain. Making sure that you are in a good headspace is also very important too. You want to, anxiety, depression definitely contribute significantly to pain and how you perceive and process pain. And just making sure you're in a positive environment is also very valuable too.
So I guess there's a lot more psychology involved here than what I was thinking with pain.
Right, yeah, so pain involves the biopsychosocial model. So it's the biology, so do you have an actual anatomic problem? The psychological aspect of things, so are you in the right headspace? Any anxiety, depression, are those being managed? And then the social component of things, are you in a safe environment? Do you have support? Do you feel like you're performing to your fullest capability in terms of, how you're contributing to society? And so those all contribute to how you process your pain.
Have you ever had to give up on somebody?
I don't think we ever give up. There are some challenging patients that we try to come up with different solutions for. In our training, we learn a lot of tricks, a lot of different interventions, a lot of ways to communicate. I think another thing that we provide is hope. And although we may not have the magic pill that can fix a problem right away, we can help direct them to different strategies to try. And it may be journaling. It might be going on a long walk. It might be listening to the birds sing. And that can be therapeutic in itself. It might be surrounding yourself with people you enjoy being around. And sometimes it takes...
that sometimes can be impossibly hard to get to.
Exactly. So I never said my solutions were easy. But, even a simple thing that you may overlook or not think about can be valuable in how you perceive your pain. And so I don't think we've ever given up on a patient, honestly.
It's just finding the right place.
Yeah, and being able to hear what their problem is that day and how we can help and what resources we can connect them with, or how even sometimes listening is therapeutic.
Well, that is all most interesting. We are here with Dr. Sanal Agarwal, and I hope I did okay on pronouncing it. He is with the Pain Management Center at Self Regional Healthcare. If you've got a question or a comment here this afternoon, you know the number, 864-332-9355, 864-332-9355. We're going to take a quick break and hear a word from some of our great sponsors right here on WCRS. So you stay with us, and we will be right back. Let's get that word, and don't you go away. This is WCRS Radio. Take it away. Screens! Rescreens, new screens. Do you need screens? Windows or doors? Call Cross Creek Glass, 864-223-3803. Next to the hospice store, 225B North Creek Boulevard. Don't let the bugs in. Get screened at Cross Creek Glass, 864-223-3803.
Shred It, Greenwood. Saturday, April 25th, 9 to 12, at St. Mark United Methodist Church on the Bypass. We will shred any personal documents with your info. Don't forget, e-waste recycling is available. TV, computers, printers, and such. No phones, keyboards, or computer mice accepted. Free to Greenwood residents only. Sorry, no businesses. Donations gladly accepted. See you on Saturday, April 25th. Let's shred it, Greenwood.
Once again, we're ready for a start. They're off in the Kentucky Derby.
Final days to get your tickets to the can't-miss event of the season, the Museum Derby Party, Saturday, May 2nd. Tickets must be purchased by April 30th. Call 864-229-7093. No tickets sold at the door, so come be part of the action. From hat contests, mint juleps, derby food, games, wine pull, and bourbon tasting. Live music by Buckland, plus the fastest 2 minutes in sports. Live on the big screen. The Greenwood Museum Derby Party. Call today, 864-229-7093. Don't miss it.
They're coming down to the wire. He's coming up on the inside. Oh, my goodness. The longest shot has won the Kentucky Derby.
Self Regional Healthcare is currently hiring for clinical and support staff positions. At Self Regional, we strive to create the best experience for our patients and our team members. We offer flexible schedules, competitive pay, and generous benefits in an environment that is supportive of your individual needs. Come see what makes Self Regional a great place to work. View our current job openings at selfregional.org/careers.
That's right. We're right back here at WCRS Radio. My very special guest this morning, he feels your pain. Dr. Sanal Agarwal. He is with the Pain Management Center at Self Regional Healthcare. We're talking about people's pain, how to manage it. And, you know, I think that is so important because just going for opioids isn't the answer, is it?
No, it's not. And that alone will cause more problems than it's fixing long term.
Yeah. So being able to have alternatives is a great way to go. Now, how do you work with primary care doctors? I mean, could somebody be seeing you for pain management while they're still seeing their primary doctors?
Absolutely, yes. So our primary care doctors that we work with are very instrumental in the care for our patients. So, you know, typically in most situations, they'll have seen the patient first. And so they've already established care with the patient. They treat the patient holistically. So if it's pain, that's one component of what they're taking care of, but they're taking care of a whole slew of other things. And so it's helpful for us to be able to take some of that onus, some of that care off their plate and be able to provide a specialized approach for managing some of these problems. And so a lot of times they've been on an initial approach to addressing their pains, mostly pharmacologic, sometimes complementary therapies as well. So things like physical therapy, occupational therapy, they may have tried those in the past. But if patients aren't responding to those other therapies, that's when we have more value, and we can provide some additional management of those medications. Our comfort level with different medications is strong. And then we also provide interventions that we have a technical expertise to be able to do. And then also, consideration for opioid management if that's the right thing for patients. And then also connecting them with resources that we know about in the community is very valuable as well.
So what about hypnosis? Do you do any hypnosis?
So we currently don't offer any hypnosis right now.
Does that work?
I believe it does work.
I'm just asking a question. Yeah.
So, part of the reason that I came on the show was to engage in the community and see if there are additional partners in the community that be able to work with our pain group to provide care for our patients. And so hypnosis is one, acupuncture is another, cognitive behavioral therapy is something that we're continuing to grow as well. I know a lot of folks benefit from things like Tai Chi. And so we've also started up having patients go to do aqua therapy at the YMCA. And so that's been a great initiative that we've been able to do. But there are lots of different approaches to managing pain, and hypnosis is one that's worked for some people.
I had acupuncture one time. I had a pain in my shoulder right back there. And you are going to laugh at this story. There used to be a Chinese, it's still the same restaurant. It's had several different owners. But anyways, it was, we used to go in there, and I was telling the gal, oh, my shoulder just hurts. She goes, I can help you. I was like, we're in a Chinese restaurant. How are you going to help me? And she actually, back in China, was an acupuncturist.
Okay.
But she was not one here in the United States.
Gotcha.
And this was back in the late 80s, early 90s, and she gave me my own set of needles, and I didn't do it on myself, but I sat there at the Chinese restaurant and had her put the needles in. And do you know, to this day, I do not have any pain.
Well, that's fantastic. I think when we're partnering up with someone, we want to make sure maybe it's in a more professional setting than that, and that they have appropriate credentialing to do it. But right. I'm glad it worked out for you.
She just was not able to get. I don't know whether she was legal or not. I don't. But I succumbed to it, and I said, "Well, if these are my needles," but it was amazing.
Yeah, it works.
I think. People don't realize some of the different things that are available, right?
Absolutely. And that's part of our role, is to help educate patients on what is available. A lot of people read on Dr. Google, or they go on YouTube or Instagram or TikTok, and that's where they get their information from. But, we also know what's available in the community here and what the recommendations are for certain conditions.
It is dangerous to go on Dr. Google and find out and see if there are really things that will fix up stuff, right? And on Facebook, you are getting constantly barraged. If you happen to look at one ad one time, you're going to see 500 ads after that, right?
Absolutely. I get plenty of ads on my Facebook for all sorts of things these days.
Exactly. So it is important to go to a doctor that knows what's going on and can help you. Now, you've been able to see a reduction in opioids usage? Isn't that opioids used to be what everybody went to, right? That was pretty much, I'm talking about several years ago, and now they're trying to come up with alternatives.
Right. Generally, I think the thought is to be more thoughtful. So opioids still have a role for folks, and so there is a lot of utility to it, but it has to be managed thoughtfully. So if you set somebody up on medications to take at the same time every day for 20 years, that's not really thoughtful in how you're practicing medicine or how you're managing that patient. It's been well known that opioids, folks develop tolerance to those medications. So maybe once upon a time they used to work for 12 hours or 8 hours, and now they work for 7 or 6, and then gradually 5 or 4. And so you need to take it more frequently. And so you start to take it more frequently. Instead of 3 times a day, you're taking it 4 times a day, and then that doesn't even do it. So then you need a higher dose of the medication. Initially you were taking 5 milligrams, now you're taking 7.5. And that gave you the relief that you once had, but that starts to fade, and then you need 10. And so it's a common thing that we see, is that people start to need more a higher dose and need it more frequently. And so if you're not rotating the medication, or what I counsel my patients on is, there's not very much that you do 3 times a day. Maybe you eat 3 times a day. If you smoke cigarettes, you're probably doing that at least 3 times a day as well, but not much else. And so you typically get hungry at the same time every day, and that's because you've trained your brain to get hungry at the same time every day, even though food is not technically addictive. Now imagine doing that with an opioid medication that you're taking at the same time every day, first thing when you wake up, last thing when you go to bed. But now add on the component that it is known to be an addictive medication. So you've created the habit, plus it has an addictive potential. It's going to be very hard to break that. And, people get some euphoria. They may or may not appreciate it. They also may get some motivation out of the medication. But that's not the purpose of the medication. The purpose of the medication is for pain management. And so those other things are the problematic parts of the medication. And so, yes, there has been a decrease across the country in opioid management or in opioid prescribing. I think that is somewhat healthy, but again, there is a role for the medication. And so it's not right, I think, to withhold a medication that also has utility as long as it's used responsibly.
Well, I know that they used to give him when you like particularly for a tooth procedure and this type of thing, they gave them for longer days, right? Now they're trying to just give it for 2 or 3 days. Right.
So I actually worked with the team that helped recreate guidelines for acute prescribing of opioids at Michigan. So there's do a shout out to Michigan Open Opioid Prescribing Engagement Network. So I did a research fellowship up there, and they were doing some good work for acute prescribing. So for different surgeries, they came up with guidelines for how to prescribe these medications. And so across the country, different providers have adopted that prescribing recommendation, and it's resulted in less time that people are taking the medication after a particular surgery. That being said, people still have been on some of these medications for a long time, and for those patients, it's a little bit more challenging to taper or wean their dosing down, and that's where myself comes in handy, and also one of our addiction specialists, Dr. Gaspard, who's been very helpful for managing folks who need to have thoughtful care for their medication prescribing.
So we've talked about chronic pain, we've talked about your team over there. Now, I understand there's a lot of new drugs always coming out too, not necessarily opioids, but different type of drugs. I guess you're finding that a lot of those are helpful too? Yeah,
so a lot of the medications that we use have been well established. We use some nerve pain medications, some muscle relaxant medications, anti-inflammatories. Those are the common ones that we use. There's a new medication that is gaining a lot of reputation or regard that's being prescribed typically for acute pain. So it's called Jurnavix, and that's one that we're not currently using with chronic pain. There's no approvals for it, but there's some hope that eventually there may be some conditions that could benefit from those types of medications.
So we talked about that scooping out process, and then you've got those neurotransmitters that you put in. What's the most popular way to deal with back pain?
So it depends on the type of back pain. So the most popular, the one that I think we do most frequently, is probably an epidural. And so that is an injection outside of where the spinal canal is, or spinal cord is, where we put steroid, some numbing medication, typically some saline as well, to help it spread. And that mechanism, so when you have a lot of tightness around those nerves, when you have irritation around those nerves, your body releases inflammatory chemicals. And those inflammatory chemicals are what contribute to the pain. The nerve itself is not getting squished on to the point where it's dying, but it's irritated. It's like an unwelcome neighbor. And so when we put steroid there, we flush out those dirty chemicals that are responsible for the inflammation.
That your body is creating.
That your body has created, and then the steroid makes it so they don't come back while the steroid is there. Now, your body absorbs the steroid over about a course of 3 months, and during that time, those chemicals return, and you may start to have that pain come back. So that's probably the most common procedure that we do for nerve problems in the back. For arthritis-related problems, we do a procedure called a radiofrequency ablation. And so that is where we burn certain nerves in the back that are responsible just for sensation of the joints of the back. And so when we see folks in clinic, we examine them, we see where they're having their pain, And sometimes, but not always, we use imaging to help guide us too in terms of where people have their most arthritis. And then when we do the procedure itself, we identify where those nerves live, and we do 2 sets of what are called test blocks or diagnostic blocks. And so we don't want to just casually burn nerves. It's not something that we...
Sounds positive.
Right. And so we want to identify the correct area, and the best way to do that is just to put numbing medication at those areas. And so typically we choose 6 total locations, 3 on the left and 3 on the right, if people are having pain on both sides. And we see for about a day if people get relief. And if they get great relief for that day, they're like, yeah, my back was numb in the area that normally bothers me, then we do it again. We have to double check our work. And if we double check our work and again their pain relief is improved, or their pain is improved, then we burn them the 3rd time. And typically that process lasts about 6 months. So the nerve is kind of melted or withered away, and then it regrows over the course of about 6 months. And once those nerves reattach or reconnect, you start to feel the arthritis in that area again. And so people sometimes describe they can hear like grinding and clicking in their back. And I don't change that. The arthritis is still there. But when you hear that sensation, it should not be painful. And so those are the 2 most common things. And then the 3rd one that we do is another joint called your sacroiliac joint, and that's where your hip and your back meet each other. And so people complain when they're doing dishes or sweeping or doing laundry or household chores, and I don't think it's just an excuse to get out of those household chores.
Say, are you sure?
It may be for some people, but we do joint injections for those folks to help temporarily. And then our neurosurgical colleagues help with a procedure where they do a fusion of the joints. So they can make it so that joint doesn't have the same mobility in that area to make it so it's not as painful long term.
Wow. Well, this is all fascinating. And so what are you hoping? You did say earlier that you were hoping if there were some alternative procedures that you might find these in the community by being here on the radio. But what if for general folks, what are you hoping that people learn that they may not have known about the Pain Management Center at Self Regional?
Yeah, so I'm hoping that people realize that we're here to provide thoughtful care for them. And so we try to communicate, we try to listen, we try to provide our expertise and share that with patients and try to empower them and educate. I think those are all important parts of our care, in addition to prescribing medications, interventions, and connecting you with certain other resources. So, our motivation is to help this community and to be thoughtful in our management.
Now, insurance covers this?
It covers many things depending on the insurance. Now, insurance is a tricky battle that we're always facing. And so we are pretty persistent from our team. I didn't mention one person, Savannah Clark, who's one of our prior authorization, actually I didn't mention a couple people, but prior authorization specialist. So she helps with getting everything approved. And she does a wonderful job getting patients approved for procedures in a timely fashion. Natasha Naderi is another manager, and she's kind of a jack of all trades. I don't know exactly what her role is, but she helps with prior authorizations, helps with the CMAs, helps with kind of making the whole show go. And so she's been very instrumental in also helping patients get care in a timely fashion.
Now, where is your office at?
Yeah, so we're in the main hospital. We're kind of spread in 2 different locations. Our clinic is based on the 4th floor at Self Regional, the main hospital. And our procedure areas, where we have our x-ray machines, are on the 1st floor across from the radiology suite. Now, they're planning on having us shift around a little bit. My understanding is they're creating 4 new procedure rooms for us on the 1st floor, and that will be hopefully happening soon. And we are expanding our presence to Lawrence as well in the next several months.
Wow. So if people are in pain, they should speak to their doctor and then have the doctor refer them.
Yes.
I mean, they can't just call you up and say, I want to come on down for a consult.
No, so they should be evaluated by typically their primary care doctor. Often our referrals come from our neurosurgical colleagues or orthopedic colleagues, and evaluate, is this a chronic issue? So oftentimes, if the patient is just now realizing that they're having pain, they should probably go to their primary care doctor first and see what their primary care doctor can do for them. Now, if it persists and despite more conservative things that their primary care doctor is able to offer, then we can provide additional expertise on that.
So what do you do for the person that says, I don't want to take any drugs?
Sure.
I mean, what do you do for them and help them with their pain?
Right. So try to
that would be me. That
right.
would be
so
me.
try
I
to
don't want any
understand
drugs.
what the first try to understand what their concern is with the medications. And so, a lot of times it's a risk benefit type of discussion. So everything has a risk, and some things have a benefit. So if to that particular individual the benefit or the theoretical benefit of that medication is worth those potential risks, then that's some education that was done, and that may change the mind of the patient. But that's not my goal necessarily. Can offer interventions if that's something that a patient is interested in, if their pathology or problem can improve with that. And then
such as the ice cream cone scooping.
and usually, the ice cream scooper is further down the line than some of these other interventions.
Well, you'll have to watch the podcast to find out what that's about. That's all I have to say. Yeah, there you go.
And then complementary therapy. So, if physical therapy or occupational therapy can be beneficial, we direct them to that as one possible resource. Something simple like a heating pad can be helpful for a lot of people who have muscle pain. Some people who are okay with an intervention and who have muscle pain, a trigger point injection can be helpful, which is where you needle those muscles, or dry needling, which is something a physical therapist can be helpful for. There's also a device called a transcutaneous electrical nerve stimulator, or TENS unit, can be helpful. And basically what that
sounds pretty cutting edge here.
It sounds fancier probably than it is, but it's basically you put a sticker on the area of your muscle that's sore, and you can send an electrical signal to stimulate those muscles to override the pain that's in that area. And so that's something that's helpful for folks. And then there are also supplements that are available. So over the counter, you can get different supplements. You can get different ointments or creams. You can get patches, things like lidocaine patches. Voltaren gel is an anti-inflammatory gel that you can apply for arthritis-related pain.
So really what you're telling me is that you don't necessarily have to be going to the pain clinic or to the pain management center for heavy-duty drugs, for lack of a better way to say it.
It depends on, for any doctor is able to prescribe the medications that I prescribe.
Sure.
So you do not need to come to the pain clinic to have a prescription. However, that's not all that we offer in the clinic.
Well, that's what I'm getting at. You are able to identify and may be able to identify some more, shall we say, inexpensive or over-the-counter type things that could help people without having to go with a heavy-duty regimen or surgery or anything like that.
Exactly, and try to understand what the patient's goals are and what they're capable of doing as well, in terms of, like we talked about, sometimes insurance can be a limitation. Sometimes the social model can be a limitation with regard to, cost of supplements. And so we try to understand what the patient's situation is, what they're willing to try, and try to work with them on it.
That's pretty interesting. I did not realize that. And we are talking with Dr. Sunil Agarwal, and he is with the Pain Management Center at Self Regional Healthcare. So you are really doing all this. How big a problem? How big do you think pain management is going to be in the future?
Here itself, or
in the world itself.
I think just about everybody has pain as they live longer. Arthritis is a problem that we don't have a great solution to solve. Anxiety is a problem that is growing, and we don't have great solutions to solve. Depression is a growing problem also. And like I mentioned, the biopsychosocial model are all involved in pain. And so all of these things, and the social aspect of things, is not necessarily changing significantly either. So all three of these things are growing problems. And so I anticipate that pain is going to be a problem that our aging population will continue to experience. And so we will keep on working on creative solutions to try to address problems as they come up.
What do you think of what is they just went to the moon, okay? What do you think with some of this anti-gravity stuff?
Yeah.
Do you think that some of that may have possibilities to help with pain?
I think so. I think there's some innovative technologies that I've heard about and I've had patients anecdotally tell me have worked for them. So there's a very expensive technology called Beamer technology, which
Beamer?
yeah, it's I think BEMR, but it's a magnet that
I thought that had to do with BMWs. Beamer technology.
It's probably that expensive.
Okay.
But basically, you have iron in your blood, and so there's some thought that it can change blood flow in certain areas with some magnetic pull, and can help with inflammation and with pain. And so
That is fascinating.
I've had a
isn't
couple
it?
patients who were able to afford this technology. It's not covered by insurance.
Right.
That have sworn by it, and they love it.
Do
And
you have to keep doing it? Do they have to keep
they
doing
do
it?
it. Yeah, they do it periodically. But it's something that some chiropractors had it available in their office that they were able to offer some patients. Some of my patients had one of their own. But that is an interesting thought, and
Right.
it definitely has potential to innovate and contribute to helping people with pain.
What do you think about the future of medicine with AI and all of this happening? I mean, do you apply any use of AI in what you're doing?
Well, I think the future is bright in medicine. I think AI will be a very useful tool in medicine. I do use artificial intelligence all the time. Whether or not that helps with me even counseling people, it can give me advice to how to structure my counseling for a certain patient,
Right.
or for a certain type of problem. That's pretty much the role that AI has for me at this time. But I see potential with some of the interventions even that we do, where I use an ultrasound machine for some of my interventions, and I have to find the right view in order to see the structures that I'm familiar with as my landmarks to then make a decision, yeah, that's the target I want to go to. But I think artificial intelligence will be able to identify those structures well before they're optimized in the view, well before I identify them, and can help guide the physician who's actually performing the procedure.
Well, they say that in X-rays and everything, that
right.
their ability to read X-rays is
And so this would be applied, though, live. So while you're actually performing a procedure rather than a still picture of an MRI or an X-ray. And so I think there's growing interest in developing that technology. But again, I think the physician or the human component of pain is very important. Like I said, a lot of it
it's
is
very personal.
exactly. And so it's listening to the person, having a human touch, being able to provide personalized care for people.
Do you think in some aspects we're losing that in medicine?
I think that there are certain external pressures that are pushing physicians to practice a certain type of way to be able to see the workload that we need to see, or see the patient population that we need to see. And so we are able to see more people now, but it's possible that the quality of care has suffered as a result of that. And that's something that I take pride in is, we take our time with each of our patients,
I think
treat
that's
people
important.
like
That's very
people,
important, yeah.
and try to, like I said, part of it is listening. So if you're not able to listen to the patient, you're holding out on some of potential therapy that a patient can benefit from.
Well, and having such a wide variety of ways to treat pain, I think, is a big advantage.
Absolutely. And so when we're talking to patients, we're actively thinking about what might work and what might not work, and then trying to see if the patient would be amenable to trying those things.
Absolutely. Well, this really has been a very fascinating conversation. We are here with Dr. Agarwal, and he is with the Pain Management Center at Self Regional Healthcare. You do have to go through your primary doctor, your surgeon, whatever, to get a consult with them. But from what I've heard today, I think it would be well worth if you're living in chronic pain. Now, the difference between acute pain and chronic pain is?
Well, chronic pain, the official definition is pain for at least 6 months. Acute pain is if you've had a recent injury that has a potential of getting better on its own without additional intervention, or, with the standard rest, icing, conservative measures. That would, something that's lingered despite those efforts is the difference.
Is the difference. So if you're living with chronic pain and you have not been to the Pain Management Center at Self Regional, you might ask your doctor to give you a referral, right?
Sure.
Absolutely. So as we get ready to close out, Sanella, what else would you like the folks to know?
Yeah, so, our program is growing pretty rapidly. Like I mentioned, we have 3 current pain doctors, 1 addiction specialist on our team. We have 3 nurse practitioners. We've actually just hired a 4th pain doctor who will be starting up in the fall. And he's currently doing his
That's
fellowship.
pretty aggressive, isn't it? Aggressive, I mean, for adding doctors and everything.
It is, but we have a growing need in terms of our patient population. We have South Regional is expanding as well. We're having a growing presence in Lawrence, and so we're hoping to develop our presence in that area as well and provide care for patients in that area as well. And we're actually looking to hire a 5th doctor too, as well as a team to help support taking care of those patients. So additional nurse practitioners, nurses, CMAs.
So it's a really growing field.
It's growing. And like I said, we're the only pain group right now in town that's actively seeing patients. And we want to be able to provide that for this community.
So I think this has been really fascinating. I think pain is such a personal topic. It does require that time where somebody can sit down and will listen to you. And I think for a lot of people, they don't always feel heard.
Absolutely. You know, when I see some patients, unfortunately, they haven't really been instructed of why they're having their pain or what's causing their pain. And so we take our time to listen to the patient. We review imaging with the patient so they can actually see on their images that's the problem area and those are not the problem areas, and this is what it looks like on a model, and this is where it goes. This is why you're having pain in your knee. It's not actually your knee, it's your back, or vice versa.
Sure.
And so for them to have an understanding or be educated, it's empowering to the patient, and I think that's therapeutic in a way too.
Absolutely. So make sure you check that out. Get familiar with that at Self. And we really need to commend Self for being, I'm going to use the word aggressive, on expanding that program.
Absolutely. Self has been very supportive of our department, and that's been wonderful to see.
Absolutely. Well, I appreciate you coming out this afternoon, Dr. Sanel Agarwal. Is that right?
Yep. Thank you
Close.
very much.
Close to right. And so you are married and you have
I am married and I have
any children?
I have 2 kids.
Two
2
kids?
boys.
How old?
I got a 4-year-old and a 1.5-year-old.
Oh my goodness, they're young ones. They're young ones. So, and it says here you like outdoor activities, hiking, traveling, and spending time with family and friends. Do you get to do the family and friends spending time?
I do. I get to spend time with my kids, and they're growing and they're active and they're a lot of fun.
They're a lot of fun. Well, that is terrific. Well, we are so glad you are here, and thank you for coming out today.
Well, thank you for having me.
This is WCRS right here in Greenwood. It's been another Meet Me at the Diner. Tomorrow morning I will be back. I am not taking a Ferris Bueller day off, although the thought is in my mind I will be here in the morning. That's going to do it for us. Oh, don't forget, if you're interested, the debate is on this evening, 7 or 7:30. Look for it. It's on all the channels to be able to find it. Thank you so much, everybody. This is WCRS Radio.